Thank you, Dr. Thank you, Dr. Ravindra Mohan. It's an honor to be here teaching in this course, and it's good to meet friends and colleagues. So I'm going to give you a little touch on the evolving paradigms or changing shifts in practice patterns in lacrimal surgery. No conflicts of interest in anything that I mentioned in this presentation. I come from a university hospital where we have a department of ophthalmology where we do a lot of multi-specialty and multidisciplinary work. So as you all know, we all meet patients with tearing, sometimes with and without discharge, and just because they don't have discharge, that doesn't mean that they do not have an nasolacrimal duct obstruction. And we know how to differentiate these patients with proximal obstructions and distal obstructions. That's just a fluorescein dye disappearance test kind of showing you a symptomatic patient itself. Before you touch these patients surgically, to ensure that you do not dealing with a patient with reflex lacrimation, but identify patients with both upper and lower, because the upper ones are much easier managed, provided in the proximal lacrimal drainage system. But as you go down the lower distal nasal obstruction, that's where the previous talk becomes very relevant. And when you look at all patients with no lower nasolacrimal duct obstructions, a good chunk of them actually are asymptomatic. These are the patients we get away with doing even intraocular surgeries just because they don't have tearing and discharge as well. But not infrequently, they present with either an acute dacryocystitis cystitis, a chronic dacryocystitis cystitis, or once in a while an acute and chronic dacryocystitis cystitis. And what are the treatment options for these patients? Historically, ophthalmologists are notorious for prescribing lubricants for patients with tearing from nasolacrimal duct obstruction. So if you are the kind of person who cannot evaluate a lacrimal system, please refer to your dacryologist or oculoplastic surgeon. And of course, external DCR has always been there in a big way. There are minimally invasive techniques, and it's still considered the gold standard. But you also heard the talk about endoscopic or endonasal DCR as well. I still see patients or encounter patients who have had a previous dacrocystectomy, and we were talking to Dr. Shruti earlier on. Unfortunately, that is still being practiced in certain parts of different parts of the world, but that is becoming completely history. And what is really new in the field of lacrimal drainage surgery, that is ELDR, and we'll talk a little bit about it today. You all knows about the pros and cons of external DCRs, considered the gold standard, what we learn, but in certain hands it works very well, certain hands it doesn't work very well. But more importantly, patients are quite averse to having extensive procedures done, especially after watching YouTube, so on and so forth. And that's where endonasal endoscopic DCR comes in, where it's almost always, at least in our practice, done under general anesthesia, which I think is a downside to it. But if you want to do a good job, I think a general anesthetic procedure is always better than a local anesthetic procedure itself. It can be done by us dacryologists, or a lot of times it can be done as a combined procedure, and I think it's a good idea to start working with your ENT colleagues in these cases. And it has several advantages, but along with these advantages come certain disadvantages. And what about the outcomes? And that's what we need to look at. Over time, our own practices evolved to such a way that the external DCR is now becoming less and less offered for our patients for various reasons. And so much so that now I teach external DCR more for exposing my fellows to dacryocystostomy rather than a real need for external DCRs. Endoscopic DCRs comprise about half the group of the patients as well, whether it's younger patients, older patients, and a good proportion of patients are having ELDRs done, and that's what I'm going to talk about the rest of the talk itself. So our patients with lacrimal drainage disorders are offered external DCRs with its pros and cons, advantages, disadvantages, and success rates, endoscopic DCRs, and we now offer routinely endoluminal duct recanalization based on patient selection for our patients as well, usually with a success rate of about 70 to 80%. Not as high as an external endoscopic DCR, but pretty good. And it's very important to understand that these can be done under local anesthesia with sometimes no sedation at all. But I'm going to show you some videos of patients done traditionally under general anesthesia itself. NUH, we have a lacrimal service where we do our own lacrimal work itself, but sometimes we do a lot of combined work itself. This is Dr. Raguraj, who's sitting in the back over here, who's learned the art of multidisciplinary management. Multidisciplinary management has completely changed the way we practice oculoplastics today. So this is very good because it helps deal with complex lacrimal obstructions. Definitely you have much better success rates when you work with your endonasal endoscopic surgeon, especially you have altered anatomy. You need to do that extra evaluation and post-operative management, which is oftentimes necessary. We started doing revision DCRs even in an outpatient setting for patients with external endoscopic DCR who start developing early scarring itself. And we now use them to start doing endoscopic orbital surgery itself. But that's the several advantages, but when patients who have thick maxilla or cannot be candidates, good candidates for GA, or patients who are keen on minimally invasive surgery. That's when endoluminal duct recanalization comes in. And the concept is going and addressing the pathological anatomy in the lower part of the nasolacrimal duct, very different from where we are doing it. So this becomes more physiological drainage of tears rather than this, which is an unphysiological drainage of tears. So we basically need to use a lacrimal endoscope, and this becomes an important instrument mainly from a diagnostic point of view, and you can start identifying certain endoluminal pathologies which were never really described. I use a German technology, which is a very fine Japanese technology which is available but not FDA approved, and hence I'm not able to use that. These are rigid or semi-rigid endoscopes that can be used itself. So here's an example of a patient who is a post-pre-op patient with NLD obstructions. Traditional middle turbinate post-endoscopic DCR or external DCR evaluation. This is the inferior turbinate. We used to sometimes amputate the inferior turbinate, and this is a natural orifice of the nasolacrimal duct below the inferior meatus, showing free positive drainage of ELDR patients itself. So short video, if it plays, yes, it does play. So you can see this is a confirmation of obstruction. You can actually assess the level of obstruction by combining your lacrimal irrigation fluid with the local anesthetic. If you have access to a good radiology setup, you can do a preoperative dacryocystogram for these patients, determine the upper and lower, and also a good educational tool. And all patients do get endoscopy. In our patients, in our system, lacrimal patients all get preoperative and postoperative endoscopy. And here you can see a lacrimal endoscope and a nasal endoscope. And this is the endoluminal view of various parts of the lacrimal system itself. There are patients where you'll start seeing narrowing of the stenosis or dacryostenosis itself. And there are patients where you'll be able to go down up to exactly where the obstruction is and exactly identify where the obstruction is. So the take-home point is the lower down the obstruction, you know that it's going to be more focal rather than a generalized obstruction. And these are the patients who are likely to improve with endoluminal duct recanalization. So that's an endoscopic view of going and taking a look inside with an endoscope. You can use the same endoscope to recanalize. You can confirm it with probing. You can do an intraoperative imaging if necessary. And in select patients, you can go ahead do a balloon dacryoplasty. This is what Dr. Ravindra Mohan was talking about, where we don't use it for all patients, but we use it for a select patients who have a slightly more than focal obstruction itself. And after doing a balloon dacryoplasty, you can do an intubate, like bicanalical intubation. Typically, I'll leave it for 4 to 6 weeks. So ideal cases for ELDRs are patients who have had a recent onset of NLDO. In other words, they have not had a chronic dacryocystitis for years, who are likely to have a diffuse obstruction, symptomatic, and even starting to treat partial and intermittent nasolacrimal duct obstructions, lower and focal NLD obstructions, patients who are on blood thinners who cannot come off blood thinners. This is a reasonably good, and most importantly, the motivated patients who are otherwise unwilling to have an external or endoscopic DCR itself. You can do various combinations of these adjuvant procedures as well, which each of it adds a little, another 5%, 7%, 8% success rate. There are costs itself, and there is concept of assisted patency. In other words, that after doing the procedure, typically in external DCR, there's no postoperative intervention follow-up, but you can go ahead, follow it up postoperative antibiotics if necessary, steroids if necessary, even a balloon dacryoplastic if necessary itself. So in summary, ELDR, I think, is a physiological procedure compared to the traditional external endoscopic DCR. We are all familiar with probing and syringing of nasolacrimal duct, and the patient acceptance is quite high. But however, a lot of it, like us human beings, it's a mindset, overcoming the traditional models of management of patients to something as well. The evidence is still not long-lived, it's short-lived. In our own series, we get about 70 to 80% success rate for these patients. And we tell those patients that if it fails, yes, we can always resort to a traditional and DCR approach itself. Yes, there is a need for instrumentation, and today we should not be living in an era of blind surgeries but visualized surgeries itself. And these patients require a little closer follow-up rather than the patients where we operate and say come back in 4 to 6 months or if you have any symptomatic conditions itself. So in summary, I think just to keep you all in mind what is in the horizon for lacrimal drainage surgeries, yes, gone are the days where the external DCR is still the gold standard. We still quote that, but endoscopic DCR is actually getting greater and greater attention, and I think in good hands, multidisciplinary approaches, we are able to deliver very good results. But you now have to be aware of patients like these who have this inferior turbinate, we are able to recanalize, and the spontaneous flow of fluorescein, nothing as gratifying as these minimally invasive procedures. It falls align the scope of minimally invasive procedures Dr. Ravindra Mohan has talked about. Thank you very much, and really appreciate it.